I'm just going to have a panoramic view of you. Is it okay to video record the session?
Yeah, sure.
Thank you. All right. Fine. Okay. Well, thank you for giving me the chance to present today. It's just going to take a few minutes to get the presentation. Ages.
So it's asking if you want to open in PowerPoint and the blue in the middle. Yeah, you've got to sign that and give your normal login passwords again. No, you can't just delete it. I did this earlier. So sign in. No, the brown one, top. Yeah. Put your normal login in again. And it will wait about 2 or 3 minutes whilst it does it.
This desk would be better if it's this way. Okay.
Put on the landscape view and then
Yeah, I think it's better that way. Can you
just rotate it like this side. Yeah.
maybe
Yeah.
My
down.
pleasure. Sorry about that. Okay, so I'm Mohammed. You all know me. I was pleased to join you guys in August. I'm presenting today about Sbar communication tool, and I think, is there anyone in the room that have never heard about Sbar communication tool? I think we all know about it. We're using it in our daily practice, and also if you're talking about bringing up the communication with different teams and the interactions, I think will be really useful to refresh our memory about how are we communicating in a structured and efficient way. So by the end of this session, I'm aiming for you guys to refresh your memory about the 4 components of Sbar communication tool, and with examples. We'll have a chance to do simulation activity to apply this, and also will illustrate an example of where Sbar communication wasn't really applied, and what are the errors, and what do you think what should have been done differently. These are the subtitles of today's presentation. So icebreaker and pre-quiz is going to be very interactive, so get your phones ready. Components of Sbar with descriptions and examples, how to apply it in different clinical scenario, interactive quiz, sim activity, and take to home message. What do you think about this food tool? What do you think about this
More interested in
lecture?
him, not the slides.
Okay. So,
You carry on.
So what do you think about this picture, and what is this, and why do you think it's related to our presentation today?
so this looks like a nuclear submarine belonging to the British Navy.
Oh,
maybe
yeah.
it could still be an Aquila submarine anyway. This is a weapon of destruction. It can house nuclear missiles. It can house Tomahawks missiles or whatever it might be. So it's a very huge military figure. And I had at some point wanted to work in a submarine, but right now I've changed my mind. So communication is key in when you're working in this kind of environment, because when you miscommunicate, that can determine the lives of thousands of people. There have been several incidences, but I don't want to go into that. So that's my understanding there.
Well, you did the job. So that's the U.S. nuclear submarine, and Sbar communication tool was firstly invented by the U.S. Navy when they feel like it's very critical environment and they need to communicate very critical information in a structured and safe way. So in late 1990s, they invented the Sbar communication tool and applied it in the nuclear submarine. And then it was adopted by health organization in USA as well in 2002, and then it was widely known as a standard way of communication between clinicians. Interestingly enough, it's not only the submarine and healthcare system. So Sbar communication tool is commonly to be used in different fields and different settings, and customer service and training in really different ways. But that's where it comes from and firstly invented. All right, let's do a very quick pre-quiz. If you get your phones ready with you, and I am going to ask you to kindly scan this code when it comes. Right, if you can scan this code, that will get you to a quiz. So let me know when you're all ready. Yeah, all ready?
Please.
Okay. So what are the main challenges you face when communicating with your colleagues? I know we've been going through a few of them in terms of like referring patients to different teams, but if you can think about what are the main challenges you think you're facing while communicating with your colleagues at the moment, if you can give an answer on the phone, the answers will come up here so we can discuss them together. What do you think? Can be short answer, a few words. Can be like a paragraph. A bit long. It's like a lot of challenges. So more concerned of being insulted or ridiculated by the other end. Okay, that's the moment that Rob talked about when things are being really escalated, and or I think it's really important to get the insight that where to stop and where to step back if you are thinking that we're not going forward to any conclusion. But that's valid concern, and I think we shouldn't really normally be worried about being insulted while we're doing a job for our patients or looking after our patients. But yeah. Any other response? Feel free to give a shout if you don't want to use the technology.
I'd say the environment that we're in.
Yeah.
Downstairs.
You mean fast-paced environments, high
The
stress?
noise, interruptions.
Yeah.
As well.
Yeah. Good one. Anyone else would like to shout and say something if you don't want to?
I agree with you. Sometimes you're on a phone trying to make a very coordinated
Yeah.
referral, and they're at the back discussing other important things anyway. Not that it's not important, it can really break you. I mean, break the whole thought
Okay,
process.
let's move to the next point. So, when receiving handover, which part of information would you consider the most important? So, you are getting handover from one of your colleagues, and what would you think? What would be in your mind? What is the most important thing you're interested to know? You're very interested to know about. Also, you can give a shout if you don't want to get answers on the board.
Expectation, what the patient wants me to do.
Yeah, very good. So a clear plan.
Yeah.
What are you asking me to do?
Yeah.
Yeah, good one.
Yeah, what has been done and what is yet to be done for this patient? I'm
Yeah.
very interested in that.
Yeah. So that's really important, isn't it? Because we don't still hand over the process that represent the continuity of care.
Yeah.
If your colleague have done something, you need to build up on this care
What they have
plan
done so
and
far.
then go to the next step, not doubling up the work. Yeah, that's good. What our assessment is, yeah, what I'm supposed to be, which is the plan. Good.
And ultimately, the nature of the patient.
Yeah.
Yeah.
Alright. So when someone asks you for advice, which part of the information do you consider most important? So one of the nurses, one of the F1s, one of the more junior colleagues are asking you for advice. What do you think the most important part you're interested to hear from the story? Do you have anything in your mind?
The history.
History, yeah? All the history.
Like why they've come in.
Yeah. So the presenting complaint and the history of presenting complaint, why we are here today.
For me, I want to build on what the F1 or the F2 is thinking, why
Yeah.
he's thinking that way, or where he's, where he has stopped in his whole thought process in terms of the overall management of the patient. Because at the same time, you want to allow that independence, you want to allow that right to exercise that knowledge and all that, and then you key in and try to streamline one or two things for the
So
your
getting
colleague.
impressions and working diagnosis
Exactly,
and
and
then
moving
getting feedback
exactly.
and reflection,
Yeah.
which is an active learning process. Yeah, well done, okay. Right, okay, so it's quite an easy question. How often do you feel you and your colleagues use the Sbar tool during communication in your daily practice? How frequent do you think it's used? Frequently? Anyone else? Right, okay. So it looks like you're doing a good job, so that's good. Okay. Alright, let's go back to our presentation. So that's a quick summary and overview about the Sbar communication tool and the components of the Sbar communication tool. Very brief description about each component. So SPAR stands for S for situation, background, assessment, and recommendation. Situation means what's happening now. So what's going on now? background, you give a brief overview about what is the post-medical history, what is the background of this problem, of what's happening now, and assessment, what have you done, what's your examination findings, what are the observations look like, what are the bloods, and any other assessments or investigations you've done, and what do you think. And then recommendations, so based on your assessment, you are telling the person you're calling or you're talking to, what do you think is the next step, what do you think is the plan. And sometimes, in our level or more junior level, we might not have this clear all the time. So we might not know exactly what to do, which is absolutely fine, and then you can make it clear to the person you are communicating to and say, well, I suspect that we might have to do this, but I'm not sure, or I have no idea what is the next step, which is absolutely fine. That's why we're working as one team, and that's why we are asking for advice and communicating with each other. So we'll talk about each component with a description and a bit of example, so that you can have a better understanding about what are we talking about. So situation, so what's happening right now, it's a really brief description of what is the problem now. An example of this is, hi, I'm Mohammed, I'm one of the ED SHOs, I'm calling about Mr. Jones. He's 85 years old gentleman who's having difficulty breathing and appears to be deteriorating. So you don't need to tell the whole story from the beginning, but you need to give the person a brief description of what is really happening, what's wrong now, in a brief description and organized way. Background, so the context of this breathlessness, what was happening, how long it's been going on for, what is the relevant post-medical history that is related to this presenting complaint. So Mr. John presented this morning, he's got a history of COPD, he's got home oxygen 2 litres, and he's known to have heart failure, reduced ejection fraction on his echo this year. And this is really important because sometimes when we are clogging, you'll open the GP record and you will find a long list sometimes of post-medical history and comorbidities. And when you're communicating with your colleagues, either for handover or escalation, I think it's really important to find the balance between giving loads of information and also giving insufficient information. So you need to be in the middle between being informative, but at the same time giving only the relevant information to the presenting complaint or to the issue you're facing at the moment. So that's your assessment. Assessment will include any examination findings, investigation results, including bloods, scans. What are you thinking clinically is happening? Do you think the patient is deteriorating, improving, responding to the treatment, not responding to the treatment? So currently he's using 7, his oxygen saturation's dropped. With increased oxygen requirements, he's tachypneic and tachycardic, and he appears confused and overloaded, and we are thinking he's worsening despite having oxygen, antibiotics and diuretics. Recommendations, so what do you think should be the next step? What should be the plan? So as I said, you can suggest things in your mind that we might need to do. If you're not sure, say just I'm not sure what would be the next step. So in this situation, I think, and in recommendations, it's really important in the beginning to tell the person you're speaking to, either face to face or over the phone, what would you like them to do for you? So if you're asking for advice, what are you expecting the other person to help you with? Are you asking for advice over the phone? Are you worried about the patient to the point that you want them to come and physically see the patient? What are you so being clear about your expectations will facilitate the mission of the other person to be able to help you. So I recommend, I think, I'm worried about this patient, I think you need to come and see him. He may need more diuretics to float him, and might need more oxygen, treatment escalation plan because he's not improving, and I think he might not be fit enough for ITU, but I'm not sure, I can't make this decision. This is another example that we'll go through. So that's the typical looking at our clocking notes when we clock patients. So that's Mr. John Smith. He's 62 years old, gentleman in major 5. Then coming with shortness of breath, cough and fever. That's the post-medical history. He's got a background of hypertension and asthma. That's the chest X-ray findings, blood spending, using 0, and he's got right crackles on his chest. And we are treating him for CAP, and he was given IV antibiotics and IV fluids, and we're waiting for the bloods. You've seen this patient, you complete the clocking notes, your shift is finished, and you are handing over this patient to one of your colleagues. So let's apply Sbar approach on this scenario. So what would be the situation here? So, hi, I'm handing over Mr. John Smith, 62, in bed 5, presented with cough, fever and shortness of breath. That's what's happening now. He's currently being treated for possible CAP, and he's stable but continue to be breathless. So that's a brief description of what's happening now. Alright? Background. So what is in Sbar's medical history is related to his presenting complaint or to what's happening now. So he's got a history of hypertension and asthma, reported cough started 4 days ago, increasing shortness of breath and fever, chest X-ray showed right low loop consolidation. He was started on IV antibiotics, received fluid upon admission. Assessment, so that's observations and what do you think clinically about the patient, and then your recommendation. So as Effie said, you need to know about clearly what is the plan for this patient, what I am supposed to do. So the plan is to chase the inflammatory markers, and depending on the inflammatory markers, to decide either to discharge this patient with oral antibiotics or to refer him to medical team for to take over his management. Is that all right so far?
Yeah.
Any questions? Okay. Right. So let's do another quiz. So if you get your phones ready and scan this for QR code. So what do you think? So it's just like refreshing your memory and like just making sure that you're able to recall what we have said. So what S stands for, and if you can provide a very brief description of what S is about in Sbar communication tool. It shouldn't be too long paragraph, just like a few words. Yeah, what's going on? What's happening now? Is the patient presented with? Introduce yourself and the patient, what's the issue at hand. Good, fantastic. Right, okay, Nina is still writing. Give him more time. Background? Oh, I said it. Relevant history, yeah. Post-medical history and to be relevant. Post-medical history. Yeah. And clinical history, what we've done, post-medical history. Yeah, well done, thank you. A for assessment. What are your findings? Initial impression. What we have found on examination and investigations. Yeah, that's correct. Well Well done. And R is recommendations, further plans, or more admission. What's the next plan? Yeah. Well done. Thank you very much for your interactions. Where's the mouse going? So we've done this example. Okay. So we're here so far in the middle. Right, okay. So that's the case scenario. We'll go through it and I'd like you to think about it and reflect and you tell me what do you think should have gone differently that would have led to different outcome. So that's an 80-year-old lady with a complex urological history, including recurrent UTIs, presented to ED with acute urinary retention with 800 ml in her blood or scan. In the initial ED visit, so during her first visit, she's got catheter inserted, relieved her retention, she's been stabilised, feeling fine, and then the nurses referred her to the district nurse to try and talk in 1 week later. 2 weeks later, the lady returned to ED with urinary retention again, and this time, upon reviewing her medical records, we've realised that she had a very recent medical admission that she had acute urinary retention with 1200 ml in her catheter, and the medical team established that the catheter should remain as long term. And it was documented on the ED clogging that the patient's got long term catheter. What do you think? What do you think should have happened? And if you're thinking about, if we are talking today about communication and a communication tool that will help us to communicate in a structured and organized way to transfer all the important information related to the patient in an organized way. When you think about this case, again as Sbar communication tool or communication in general, what would you think should have been done differently? Or what was missing? What was the problem? Any thoughts?
So the fact it should be long-term catheter wasn't when she first came in, so presumably she should have
Yeah.
put it in anyway. So that wasn't in there.
So a long-term catheter was part of her
So she shouldn't have
medical
been
background
taught.
and of what happened. What was the situation in this case? What was wrong with her?
So she's coming with an acute urinary retention.
Yeah,
at the moment.
exactly.
Yeah.
And
And on the background, some of the information that later came in the slide should have come earlier. Like this is not the first time over the last 2 or 3 months she's coming as well with similar episodes. The latest was 2 weeks ago when she came in and the bladder scan was done and was 800. So I think in the whole build up, some of the information should have come very early in the background to really give that straight picture of what's
Yeah.
going on.
and also communicated
Yeah.
between the teams.
Yeah.
Any other thoughts? Would you like to comment? Right. Yeah. I think it's so that's a real situation, real story happened, and it might be like many things happening. It might be like this piece of information has been overlooked and it's been documented on the clogging and on the ED clogging, and what wasn't really it was really overlooked, or we didn't communicate this information to the nurses, so they've been automatically refer the patient to the district nurse, and that resulted in this poor lady to come to the hospital 3 times in 1 month, in and out, putting catheter in and out 3 times unnecessarily. Which highlights the importance of effective communication, organized communication that will help us not to miss important information about the patient, which will subsequently help us to maintain the patient safety and contribute to better patient outcomes. Right, okay. Time for some activity. So can I ask you guys, can I ask someone to volunteer? I will give you a case scenario of a patient, and then we'll do it as a group. So 2 people to volunteer, 1 doctor to volunteer to give the handover to the colleague, and then others will listen and provide feedback. It's the same thing we're doing every day, hundreds of times. So don't worry, it's not difficult. It's just handing over a patient to your colleague. Who's going to volunteer? I think. Yeah. All right. Do you want to give the handover to Kanchan?
Yeah, Kashin doesn't like my handovers. Whenever I want to hand over, I should be in the
Well,
It's serious.
let's try it this time. So that's the scenario. You've got 82 years old lady presented to the emergency department with right hip pain following a fall. She's got a history of hypertension, CKD, heart failure, BMI and type 2 diabetes, multiple blood pressure medications and long-term steroids. Initial blood tests, she's been dry, started on some IV fluids, head x-ray didn't show any fractures, and the patient is currently stable, but hair pain persists despite analgesia. There are concerns about possible head fracture. You've requested a CT scan, but your shift is finishing now.
Hi, Kashin. Want to hand over a patient. Think I've come to the end of my duty. Okay, just one, not many,
sure.
right? Yeah. The lady in M1, she's an 82-year-old patient who's had a fall today. So came with the right hip pain. On the background, she's a known hypertensive and CKD3, and she's on a lot of antihypertensive medications as well. Also, she got background type 2 diabetes and heart failure as well. So I've examined her. She's got this right hip tenderness. We've done an X-ray which really showed nothing, but with the level of pain, I'm still quite not. I'm still concerned about a possible hip fracture. Do not concern. I'm not. On X-ray, we've given her loads of analgesia, and also she's got some bits of fluid as well. So to really tie the loose end, I've requested for a CT pelvis just to look for any micro fractures that probably wouldn't have seen on X-ray. And I think that's the only job to just chase the CT scan. Whatever you find, that should determine what you do next, either Southampton or orthopedics here. Okay.
If the city is fine, then how?
Well, if the CT is fine, then PTOT can come into play, maybe in the morning, or if there's any other them around to look at it. Okay. But otherwise, just chase that for me. If you have any concerns, please, Dr. Obtorok is on call tonight. Just discuss it. All right. Thank you.
Yeah, okay.
All right, thank you very much, guys. Thank you. What do you think? What do you think about FA's handover? Anyone who's got any thoughts, any feedback?
Very clear.
If we're applying this handover against,
The only thing that I'd expect to be different on there, it doesn't say anything about her mobility normally, who she lives with, how she's going to get home,
Yeah.
that sort of thing.
yeah,
But,
I mean that,
but you haven't
yeah,
got
that
information.
information
That's
provided.
true. Very true.
Any other thoughts?
The hydration and the fluid you gave, do you want her to also reassess after the fluid has gone through? Do you want her to also reassess for the dehydration or not?
Well-
I don't think the dehydration was a big deal here. So,
Yeah,
was
we just from the
situation here?
it's just
What-
the situation on the board.
What do you think is the situation here? What was happening? What's happening right now?
The situation is the fall have come in with hip pain.
So that's the situation. So
Yeah.
this lady had a fall. She's having persisting right hip pain despite analgesia.
Yeah.
That's the situation. I'm handing over because we are worried about fracture, as you mentioned. Going to the background, from this list of comorbidities, what do you think is most relevant to the patient presenting complaint or to this situation?
Steroids.
Yeah. So she's got to be on long-term steroids, which would make her in high risk of having osteoporosis.
He's also got multiple BP medications which can drop her blood pressure.
Yeah.
Diabetes can cause some neuropathy that could have led to the fall.
Yeah.
Hypertension, we'll go with the blood pressure. Well, CKD, some electrolyte imbalance can still. So I think for me, even the polymyalgia rheumatica can, not typically anyway. So for me, I think all of those are core risk factors that could really potentially go for.
I think if you're thinking critically about this, what's happening now is more like the right hip pain and the worry about the fracture rather than the fall. I mean, the fall has led to the fracture and the pain, but I would be more highlighting the fact that that's right hip pain, possible fracture, and I would be thinking that will be the more relevant thing to the situation. And you've mentioned the assessment in a very good way. What about recommendations? What do you think, Kanchan, about? Are you happy with the plan that Effie has given to you? Do you think it's clear and you're happy with that?
Yeah, he said if the CT was abnormal, then ortho, but what if the CT was normal? He didn't say anything about that.
Okay.
Which you asked me.
Yeah,
which is good.
Yeah, so
should
it's
be an
really good that you
interaction.
clarified the plan from him once. I think it's really important, as you mentioned earlier, to be very specific and clear about the plan. And if you're not sure about your plan, you can consult one of the registrars or the consultants to clarify what are we doing. Or we send this patient home, and always give like 2 possibilities, even if you're thinking it's definitely going to be a fracture. So right hip pain, we're going CT. What are the possibilities? So could it be NOF?
Could be NOF.
So if NOF, what would be the plan?
Fib ortho referral.
Ortho. What if it's pubic rheumatic fracture?
Medical referral, PTOT.
What if acetabular fracture?
Or someone.
So it's really 3 different possibilities with 3 different plans, and I would be a little bit more specific, explaining that, well, if the CT is normal, then we can wait for the physiotherapy and discharge the patient, or thinking about discharge the patient. Well, if the scan is abnormal, if it's not, then we can refer to orthopedic. If it's I mean, it's a bit of exaggeration.
Yeah, but is there no room? You're talking to a fellow colleague. If it's a fracture, is it going to send the patient home? I mean, what I mean by this is you're speaking to a doctor who understands that whatever comes out of the CT is a fracture.
But that would bring us to the point of being very specific and clear and not to assume. So if you've seen the patient, everyone will be expecting you to be very clear about what I'm doing for this patient. So I know that NOF will go to orthopedic, but it will be useful for you to be very specific about what are the possibilities of this. Why are you doing this test? So why have you requested a CT scan? What are you looking for? You're looking for a fracture. What are the possibilities, and what are we doing with each possibility? I think that would be more helpful to your colleague to follow up the plan based on your handover and communication. Any other thoughts about that?
I think to be fair to the guys, it depends on your assumptions about your colleague's competence, because you could say it's more efficient and brief to say if there's a fracture, deal with appropriately. If not, then I think she needs OTPT.
Yeah.
Because you're both right. You're right. You're being comprehensive and specific. If it's a fracture off that, if it's a pubic ramus that, if it's something else that. These guys are right in as much as, well, that's a lot of other information. They already know that. Therefore, it's inefficient communication, and you're just using time. They could be employed doing something else. So there's different pros and cons to that. There's no single right answer.
Yeah. Well, I agree. It's interesting that I've worked in 2 different hospitals before, Bull Hospital and Queen Elizabeth Birmingham. And the way, so for the weekends, for the medical team, the way we get hand over to the weekend team about the patients that need to be seen in the weekends, that it used to be in Birmingham, if you're saying like if patient potassium is high, give insulin, glucose, and do that. So people used to get offended by it, and they say, well, I know how to treat hyperkalemia. You don't need to tell me. On the other side, in Poole, so we used to write in Queen Elizabeth Birmingham, treat accordingly or deal with that according to the
As per
results.
protocol.
Yeah, as
Yeah,
per
as per protocol.
And then when I've done that in Poole Hospital, I think it was like completely different system. So they preferred to give like very clear instructions about what to do with this patient. So if you're thinking the patient's got chest infection, so if the patient's tachypneic, hypotensive, give IV Cormoxiclav 1.2 grams. That's the way we used to run it. Very specific. And to be honest, like I feel like it was really better, saved a lot of time, while the on-call team is very stretched and is very busy. I feel like it was a bit easier. But yeah, as you said, it's not right or wrong, and it depends on how do you feel about your colleagues.
It does. I think the other thing I'd just highlight is it depends on the setting. If you're having a one-to-one chat with a colleague and you're just handing something over personally before you run, your style and the other benefits of the communication are very different to if you're in a team handover situation with other people listening in.
Yeah.
In the team situation, you're not only handing over the patient, you are teaching and making sure that everyone's aware of the protocols and what the potential steps are. So your style and the whole focus of the communication changes a bit. So it's quite interesting. And in this setting, you know, it depends what assumptions you had as to, okay, I'm handing over, but am I handing over one-to-one in the coffee room, or am I handing over on the floor, or am I handing over in I'm being observed by my consultant, they want me to do it in a certain way because that's their preferred style. It's interesting.
Right. Okay. Different scenarios. It's really like the main two scenarios we're trying to apply today is handover from colleague to another, or escalating something to ask for advice. Can we have another volunteer? So you have a patient, you're not sure what to do with. What you're going to do is get this clinical scenario, turn around to JJ or Rob, whatever, and then ask them for advice about this patient. Who wants to volunteer? Yana? You want to? No pressure. Okay. Right, so this patient, 70 years old gentleman, presented to ED with short of breath and tachycardia, treated for cabin with IV antibiotics and IV fluids. However, receiving treatment, he's not showing any signs of improvement. His respiratory has increased to 30. He's becoming lethargic. You're suspecting that the patient might need a higher level of care or change in treatment plan, might have a PE, another thing, you're not sure. What would be the next step? And it's not about, our focus now is not about the clinical scenario, what clinically to do with this patient. It's about how to communicate, how to tell your colleague about this patient, and how to ask them to help you with this patient.
So I'll escalate to one of my seniors.
Yeah, JJ is here.
Hi JJ, I'm Yana, one of the EBSHOs. I have a patient in Rhesus 1, 70-year-old male, who came in initially shortness of breath and tachycardia. And my initial impression for this patient was community-acquired pneumonia. So I've started him on some IV antibiotics and IV fluids, but I'm concerned that he's continuing to deteriorate. His respiratory rate has increased. He's tachypneic at 30 at the moment, and he's becoming more and more lethargic. I just think the patient might need further, might need senior review and further investigations. Perhaps he might have something else going on. Can you?
How is the patient's blood pressure?
Trust JJ. JJ will bamboozle you and then.
Take the patient, not the number.
That's him.
It's important because patients hypotensive at the same time is different.
Yeah.
Right, okay. Well done. Yeah, that's good. So I think Kiana was able to start with explaining what's wrong, what's happening. She had a patient, tachypneic, tachycardic, She's treating infection. He had the treatment, he didn't improve, and she was asking for further advice about what to do with the patient. You've mentioned your assessment. You've mentioned some of the observation findings and the information mentioned in the clinical scenario, and you've added then at the end what your recommendations might be. Do you think this patient, something else is happening? He had the antibiotics and fluids in, he didn't improve. So what would you suggest that I'm doing? Then JJ can ask you what is the blood pressure looks like, asking more about post-medical history or about investigations you might have done, you might haven't done, and then you can go to the next step of treating your patients. Anyone has got any questions so far? Yeah.
Can I just make a suggestion to the group that you think about what you think situation means with the focus of communication. So what's happening is we're presenting in a fairly history, examination, investigation sort of sense. If I'm a busy registrar or consultant and someone comes to me and starts talking to me, the background question in my head is, what do they want from me?
Yeah.
So if you interpret the situation as what's happening with the patient, where they've come from, what you think is going on, and don't tell the senior until the end, I want to know if I should do a CTPA for a PE, or I don't know which antibiotics to give, or I don't know whether to refer. They're sitting listening to all of that, thinking, what do they want from this? What do they want from this? So I promote to you the suggestion that instead of thinking about the situation being based on the patient, think about it in communication terms. Why am I communicating with this person? So, hi Mo, I've got a patient I'd like to discuss with you because I don't know whether they need a CTPA or I need to get I2 involved.
Yeah.
The background is they're a 70-year-old male with shortness of breath, blah, 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 blah. Do you see how I've just changed it and I've given the senior the kind of context of why I'm going to give them all the rest of this information before I then give it, because otherwise they're kind of listening but kind of trying to guess, where's this going? What's the question going to be? Is it going to be, do I want augmentin or clarithromycin? Is it going to be, do I need a CT or can I send them home? Is it going to be, can you come down and assess them? It's just a slightly different emphasis, and it really helps. Really helps.
Yeah. Well, thanks for bringing this up. I think
it's probably our next point, isn't it?
Yeah, what we mentioned earlier about.
Can you remember my typical question? What is your question?
Yeah, when you
I'm
talk
always asking you.
Yeah, so it's very
Go straight to
useful
the point. What do you
to
mean?
tell the other person what are you expecting them to do for you.
Exactly.
Or are you expecting them for an advice? What kind of advice? What's your question? Or are you expecting them to come and see the patient if you were it?
We're hitting the time buffers, just so you know. It's 47 minutes past and we're supposed to be out 2 minutes ago.
Fine, we're finishing. So that's the take-home message. So Sbar communication, structured communication is really important in the clinical setting. High pressure environments, like emergency department. Balance is a key. So balance between providing too much information and insufficient information should be in the middle, concise and informative. Prioritize essential information. So if you're thinking that part of the post-medical history is more relevant to the presenting complaint, that should come first. That will help the other person to make a decision or help you about what you're asking about. The more you organise, the more you're clear, the more the other person will be able to help you, and that will, at the end, enhance the patient safety and contribute to better patient outcomes. Any questions? Right. Thank you very much.
So most Sbars, sorry, I'm a little bit of a rule breaker. I mean, I don't. Yeah, guidelines and all these structures are pretty fine. And just like if you watch how Rob restructured his own, he didn't really follow the Sbar as part following the way. Yeah, he did, but typically the way we are expected to now dance around the situation, dance around the background and all that. Let's assume I'm meeting JJ on a night shift. I know JJ is everywhere, he's in EDAU, and I mean, I have a patient using, maybe CAP, like the case you presented, using at 9, and you're caught in between that scenario. You just need that quick JJ's input as to what next can I do for this patient.
Yeah.
JJ, I have this 78-year-old man. He's in Resource 1. JJ came in with cough and shortness of breath. We've started antibiotics. Nothing seemed to be working. But I'm concerned about this. His heart rate is 150. His sinus, I'm thinking probably he may have PE. I mean, what do you suggest? Like, I mean, because the two scenarios you created here is one of a normal handover, and then the second is of escalating a particular case. Because if you really want to escalate, you need that brief, concise advice or straightforward information as to what you can do, like the one you say, query PE and all that. So, I mean, yeah, Sbar is fine, but I think in a very high pressure environment whereby you need that quick input to be able to justify your suspicion or probably escalate, like the other scenario said, you see that the Sbar team, you wouldn't really be thinking about heart failure. I mean, I don't know what I'm talking about. Yeah, I don't know if I'm making any sense. I mean, I'm trying to communicate the best way.
You should be flexible, adjusting or way of communication.
Yeah,
depending
kind
on
of.
the
Yeah,
situation. But I would say if you are, so it depends really on the situation. If you are giving a very good brief description of the situation, and that was enough for the other person to make a decision,
okay,
then that's fine. You're not gonna have to go through
yeah.
and background and assessments and recommendations.
Cool.
And like for example, if you're having a patient with NOF and you're not sure about the refer both ways, and you're asking, well, which team should I refer this patient to?
Follow the
It's a tool, isn't it, that is useful for some situations, and different personalities and different dynamics will direct you which tool to use any time. But it does work. It does work.
So if you have a very specific question about something, you don't have to go through Sbar communication tool. This tool was created to organize good amount of information in a way that the other person will make it easier for the other person to give you advice upon, or will help you, colleague, to follow your plan depending on your assessment on the work.
And some of these tools you can use if communication breaks down, and you can say, look, I don't think we're communicating effectively here. I don't think you're getting my point. Should we use the Sbar? So let's rephrase this. The situation is this, the background is this. Keep going because time's done. Cool.
Feedback, please, if you can scan this.
So please take the time to feedback because you need this for your.
It's a Google form, quite straightforward to.
And once you've got it, can you please share it with JJ so he's got a copy of.
Sure.
And it's anonymised, isn't it?
Yeah.
So people.
Don't worry.
People give it back and then whatever. Lovely. Once you've done that, can you go back and hit the floor, please?
Yeah.
Can you